Hi everyone, this is your podcast for bipolar disorders. Bipolar disorder is a recurrent mood disorder that includes episodes of mania or mixed episodes of mania and depression. One would describe his or her life with bipolar disorder as a roller coaster. Exciting, scary, unpredictable, with precipitous drops and spectacular peaks. Kind of like this picture. It's out in Colorado. I was there a couple times, and when I read that description, I thought, wow, I have to put in a picture of Colorado, because if you've ever been out there driving around, those roads can be downright scary with precipitous drops and spectacular peaks. You're better off looking up than you are down. The incidence of bipolar disorders, it's thought that bipolar disorders affect approximately 1% or 2 to 2.5 million of the U.S. population 18 years and older. The average age of clients experiencing their first manic episode is 18 to 20 years. Earlier age of onset is associated with worse outcomes, including rapid cycling in adulthood, and more about that later. As far as prevalence, the lifetime prevalence of bipolar disorder is 3.9%. Rates of morbidity and mortality, particularly for bipolar depression, are associated with cardiovascular, cerebrovascular, and respiratory diseases, and other psychiatric illnesses and substance use disorders. The associated risk of death by suicide in bipolar illness is 15%. A definitive cause for bipolar disorder has not been identified, but scientists agree that a combo of interaction of genes, neurobiology, environment, life history, and development can result in bipolar disorder. Some genetic factors. Bipolar disorders are highly inheritable. Dysregulation in gene GRK3 involved in dopamine metabolism increases susceptibility to bipolar disorder. When you look at neuroanatomic, there's a slide that follows that shows various brain abnormalities seen with BPD, and this picture is also in the textbook. Neurotransmitters. Mania has been associated with decreased serotonin and decreased sensitivity of serotonin receptors. Many dopaminergic drugs, if you will, have been found to trigger mania symptoms like elevated mood, energy, talkativeness. Clients may also have decreased GABA during manic episodes. So the question is, can mood disorders be related to intracellular signaling problems? When the signaling pathway is abnormal, does this lead to altered neurotransmission? Psychological factors influence how people respond to their biologic makeup and whether problems emerge. From a cognitive viewpoint, if you will, cognitive factors include faulty beliefs about self and the world, and specifically high goal attainment beliefs, which are thought to contribute to bipolar illness. Interpersonal and social rhythm model. This model posits that psychosocial stressors trigger bipolar episodes by disrupting normal social rhythms. The result here can be a disruption of circadian rhythms, leading to mania or depression. Here's a picture of the neuroanatomic issues that happen with people with bipolar. There are many famous people with bipolar disorder, and I'm sure you recognize many of these people on this list. So there are several categories, if you will, of bipolar and related disorders, all under the DSM-5. We've got bipolar 1, bipolar 2, cyclothymic disorder, bipolar disorder due to another medical condition, substance/medication-induced bipolar disorder, other specified bipolar and related disorder, and unspecified bipolar and related disorder. Some symptoms of bipolar disorders. The symptoms during depressive episodes are consistent with those of major depression. The depression is profound. The symptoms seen during manic episodes: grandiosity, rapid thoughts, actions, and speech, sleep disturbances, spending sprees, all kinds of risky behaviors, and more about these later. What you have to keep in mind here is the euphoria is extreme. So we've got the depression, which is profound, and the euphoria, which is extreme in bipolar disorder. You don't have to memorize these separate classifications. I just want you to have an understanding of how they're, described. Bipolar 1 is characterized by one or more manic episodes, usually alternating with major depressive episodes. Manic episodes begin suddenly and last from a few days to a few months. The effects of bipolar depressive episodes in terms of duration and quality of life are substantially worse than those of manic episodes. Symptoms of mania include extreme mood swings, irritability, angry outbursts, decreased sleep, extreme energy, and restlessness with easy distraction. Increased self-esteem, elation, delusions of grandeur, excessive psychomotor activity, loud and pressured speech, dress in flamboyant clothing with excessive makeup and jewelry. The feelings of grandeur result in inappropriate intrusion on the personal and environmental space of others, without recognition that this is inappropriate. Mood shifts may occur suddenly to depression, with the symptoms of severe depression manifesting. Bipolar 2 is characterized by major depressive episode current or past, and at least one hypomanic episode. Hypomania is a less severe form of mania and has no psychotic features. Bipolar 2 differs from bipolar 1 in that there is no history of a manic or mixed episode. These clients usually do not require hospitalization. Hypomania usually manifests as an elevated or irritable mood, different from the usual mood for at least 4 days. Hypomania usually occurs before major depression. Cyclothymic resembles bipolar 1 disorder, but symptoms are less severe. It is more common in women. It is almost subclinical bipolar 1 disorder. Clients experience repeated periods of non-psychotic depression and hypomania, elevated mood, rapid or accelerated speech, increased activity, and a decreased need for sleep for at least 2 years. Inflated self-esteem with excess energy are the symptoms that occur in the manic phase. Feelings of inadequacy and withdrawal seem to characterize the depression phase. Cyclothymic is characterized by a mood range, depressive and hypomanic moods, and it is a chronic condition. It can interfere with social and occupational functioning. The people report that they feel great, but others see what is going on. Rapid cycling, you can see on this slide, this is a mixed episode when the person experiences both mania and depression nearly every day for at least 1 week. And again, it's called rapid cycling. Clients have 4 or more manic episodes for at least 2 weeks in a single year. Episodes are marked by either partial or full remission for at least 2 months, or a switch to an episode of the opposite type. It's associated with a high risk of recurrence and resistance to conventional drug treatments. There's a greater severity of illness and prominent depressive symptoms. So here's a nice slide that shows you manic symptoms and depressive symptoms. Mania or cognitive manifestations have to do with that elevated self-esteem, grandiose thinking, feelings of power, flight of ideas, to the point of delusion. The person believes that he or she can't get into trouble and they are not sick. Grandiose thinking is pompous, inflated self-esteem. Flight of ideas, the ideas appear to be continuous but are fragmentary and determined by chance associations. And we also see flight of ideas with schizophrenia. Here on this next slide, dig fast, primary symptoms of a manic attack. Schizoaffective disorder. A person with schizoaffective disorder actually exhibits symptoms of both schizophrenia and an affective or mood disorder such as depression or bipolar depression. It's a mixture of depression or elation as well as psychosis, better prognosis than schizophrenia, worse than mood disorder. You can see the clinical symptoms. The client has 2 or more of the following symptoms: delusions, hallucinations, disorganized speech, disorganized behavior, negative symptoms, flat affect, muteness, and avolition. Avolition, you'll find when I use those terms, we'll learn about avolition and schizophrenia again. And this is a person who's really kind of unmotivated, if you will. And I'll talk more about that with schizophrenia. Unrecognized, undiagnosed, and untreated bipolar disorder results in high costs for both society and families. U.S. cost to treat bipolar disorder is thought to be around $24 billion per year, and that's figures from 1998. What would it cost now? The care is given. You can see the treatment settings on the slide: acute care, step-down programs, day treatment programs, community-based programs. The prognosis for patients who receive care is good, as bipolar depression is very treatable. Bipolar disorder. Most clients can return to normal functioning. Interdisciplinary treatment includes psychotherapy, pharmacotherapy, and somatic therapies. The combination of psychotherapy and meds is more effective than either alone. Again, there are treatment settings that are best equipped for the complex care needed by the client with bipolar disorder. Management of the illness includes medication management, assertive technique training, and anger management. Some common modalities of psychotherapy, there is an array of treatments that can assist clients and families with important issues. And some of those issues are medication adherence, ability to cope with environmental stress, and social and occupational functioning. Psychoeducation is education offered to individuals with mental illness and their families to help empower them and deal with their condition in an optimal way. Cognitive behavioral therapy can be accomplished via individual or group therapy, or maybe both. It attempts to modify maladaptive behavior with learned techniques, and they usually use like homework, structured schedules, and restructuring of those high goal attainment beliefs to treat bipolar disorder. Family therapy enhances family coping, communication, and problem solving. And interpersonal and social rhythm therapy is focused on helping clients stabilize their daily routines, their sleep-wake cycles, and solving key relationship problems. Some drugs used to treat bipolar disorder, these are your mood stabilizers, including lithium, anticonvulsants, and atypical antipsychotics, often combined with lithium or an anticonvulsant. And these are the primary drugs used. Lithium carbonate is really the poster child of drugs used for bipolar disorder, but there are others that are stepping up to take the place of lithium. Lithium has been around for several decades, is still widely used, is first-line treatment for bipolar disorder. And how lithium works is it alters the sodium transport in the nerve and muscle cells. It is thought to inhibit the release of norepinephrine and dopamine, but not serotonin. It takes 2 to 3 weeks to achieve therapeutic levels, and regular serum levels must be drawn to assess 3 important things. Number 1, adherence or compliance. Number 2, therapeutic level. And number 3, toxicity. Toxicity can occur when sodium levels are low and absorption is disrupted. Some predisposing factors or things that might make your sodium level low: excessive heat, diaphoresis, concurrent use of diuretics, decreased sodium intake. So some great teaching points for your patient that's taking lithium is to avoid the sun, avoid overheating, and avoid dehydration. There, as far as symptoms and symptoms of toxicity for levels, Therapeutic level is 1 to 1.5 milliequivalents per liter. Maintenance is 0.6 to 1.2 milliequivalents per liter. Toxicity starts at about 1.5 milliequivalents per liter, so it's a pretty fine balance, and anything over 2.5 milliequivalents per liter is life-threatening and can manifest as multi-organ failure, ending in death. A mild toxicity manifests lethargy, slurred speech, muscle weakness, fine hand tremor, nausea, vomiting, and diarrhea. Moderate toxicity, instead of a fine hand tremor, it's a coarse hand tremor. So there's a big change there. Mental confusion, drowsiness, lack of coordination, GI upset, and EKG changes. I'd like you to review the teaching points for clients taking lithium. It's in Chapter 16. It's actually titled that, Teaching Points for Clients Taking Lithium 16.1. Avoid caffeine. Caffeine greatly interferes with the effectiveness of lithium. And more than 1/2 of all clients with bipolar disorder are refractory to lithium, meaning the drug does not work or they can't tolerate the side effects. The next category of drugs are the anticonvulsants. And here, and I'm going to explain this first term to you, it says they affect kindling. Scientists theorize that the brain becomes increasingly sensitive to stress and shows constant abnormal activity or kindling. Lithium blocks the early stages of kindling. Carbamazepine and valproate act later. Let me explain that. Carbamazepine is the third most common drug used for mania. Valproic acid or valproate, these are particularly effective against aggressive and hostile symptoms, and you may recognize these as both anticonvulsants. And then we have kind of a new drug, if you will, lamotrigine. It hasn't been around for a hugely long time, but it's been shown to decrease manic symptoms in 74% of clients. Dangerous side effect of lamotrigine is Stevens-Johnson syndrome, and this is a severe and potentially fatal rash. If the patient on any anticonvulsant develops a rash, they should go to the ER immediately. Often, lamotrigine is combined with lithium for effective therapy. Now remember what I told you about refractory mania. This is where the atypical antipsychotics come into play. Atypical antipsychotics are used to stabilize both acute and refractory phases of bipolar disorder. Clozapine or Clozaril is especially effective, but it carries a huge danger of agranulocytosis and requires monthly testing of white blood cells. So when we have a patient that has developed agranulocytosis, some of the symptoms, sudden fever, chills, a sore throat, weakness in the limbs. The mouth and gums may be sore, mouth ulcers can develop, and gums might begin to bleed. Other signs of agranulocytosis can include tachycardia. There are some non-pharmacologic somatic interventions for treating bipolar disorder. So these somatic modalities continue to be investigated. So the first one you see is sleep deprivation. This is used for clients with depressed mood. The treatment is either total, where they stay awake all night, or partial, they stay awake the second half of the night. No sleeping after the treatment, as sleep following the treatment can lead to relapse. A TMS, which is transcranial magnetic stimulation, is often used for seizure disorder, but studies about its effectiveness with bipolar disorder have been mixed. VNS, or vagal nerve stimulation, alters the functional activity of the thalamus, hypothalamus, cingulate, and hippocampus, and they actually increase the concentration of something called homovanillic acid, which is a dopamine metabolite in the CSF. This therapy has been shown to treat depression and bipolar disorder with results lasting as long as 1 year after treatment. So that shows some pretty good promise. Nursing assessment for clients with bipolar disorders, particularly during a manic phase, involves systematic, thorough consideration of safety and mental status, including affect, thought processes, and intellectual functioning. Physiologic integrity and function is an issue in manic patients. Hyperactivity results in an inability to sit still in the time needed to eat a meal. They tend to neglect food and fluids. Disturbed sleep is an issue. They may not sleep for days. The typical pattern may be a brief nap followed by excessive activity. And it sounds like some toddlers that we might know. Hyperarousal, hypersexuality, promiscuous behavior, and of course, with the resultant risk for STDs occur. Assess the family as well. With mania in the client, the family feels burned out, angry, and frustrated trying to manage these behaviors at home. Assess med use. Many clients stop taking the drug when they're feeling well. Manic, not depressed. The patient may self-medicate also. Although the client is experiencing grandiose schemes and manipulative tactics, there exists an underlying fear of losing control. Set limits and address behaviors that are unacceptable. Discuss possible alternative behaviors so the client will know that the staff allows other behaviors such as walking, exercising, painting. Also convey acceptance, honesty, and empathy. Some of our major nursing considerations: safety, nutrition, rest. We need a calm environment or a low stimulation milieu. We need consistent care, limit setting, and address those unacceptable behaviors. Nursing diagnoses: risks for other directed violence, ineffective health maintenance, impaired social interaction, disturbed thought processes, ineffective therapeutic regimen management, and there are others. Some desired outcomes for clients with mania: impulse self-control. The client will remain safe throughout hospitalization without harming others. Aggression self-control. The client will demonstrate self-control in milieu activities, appropriate boundaries, refraining from aggressive and risky behaviors. For some examples. Self-care status: the client will have adequate food and fluid intake, balanced sleep, rest with activity, and will maintain personal care. Social interaction skills: the client will engage in appropriate social behavior. Concentration: the client will demonstrate logical, reality-based thought processes. Compliance behavior: the client will consistently maintain the pharmacologic regimen, including medication adherence, follow-up with provider, and lab work completed as necessary. Nurses use many types of interventions to assist recovering clients and families related to the management of mania. Nursing interventions related to the management of mania include active listening, behavior management or managing that overactivity, behavior management, managing those sexual overtones or the promiscuous behaviors, cognitive restructuring, coping enhancement, guilt work facilitation, because remember, these are high goal attainers, so sometimes you have to help them with those guilty feelings they have when they don't accomplish their goals, and limit setting. Your textbook has a great section on all of these, and it is in Chapter 28 for both the 7th and 8th edition, and it is mapped to your reading for bipolar disorder. Nursing intervention classifications: again, we have mood management, self-esteem enhancement, simple guided imagery, simple relaxation therapy, socialization enhancement, spiritual support, and teaching about the disease process. How do we know if our interventions have worked? Well, the client refrains from acting aggressively toward others. The client ingests adequate calories and fluids, maintains a balance between rest and activity, and independently manages self-care. The client participates appropriately in milieu activities and social interactions, and the client expresses a positive sense of self-worth without delusions of grandeur. And the client demonstrates logical thought processes. The client reports reduced anxiety and agitation. The client adheres to the therapeutic regimen and discusses the importance of doing so after discharge. Improvement of symptoms is gradual but noticeable as interventions take effect. You should review the client-centered education also in the chapter about bipolar disorder, helping your loved one with bipolar. And that's the end of this podcast.